Okay, so I said it wrong in the last video. So cranial nerve 12, we're assessing in the client who sustained a stroke. The nurse assesses the cranial nerve, which action should the nurse ask the client to perform? Extend the arms, extend the tongue, turn the head towards the nurse's arms, focus the eyes on an object held by the nurse. So it is cranial nerve 12 is extend the tongue, that's a hypoglossal nerve. Okay, so the next section is to inspect and palpate the motor system. So some things you want to look at are size, strength, tone, and any involuntary movements. So as you're going through, and we talked a little bit, I think in the musculoskeletal section about strength, we did, and you're grading strength 0 to 5. 5 is full strength. When we're looking at size, you want to compare the right with the left. So if one muscle group, let's say somebody's right bicep is a lot bigger than their left bicep, you would want to note that. That would be abnormal. Tone is the normal degree of tension or contraction in a voluntary relaxed muscle. So that muscle is relaxed, it's not tense, and you're going to feel that. Tell the person to go loose like a rag doll is what your book says. So you would want to check for any spasticity and rigidity that can occur with weakness. And then any involuntary movements like tricks or tremors, chorea, things like that. All right, for the cerebellar function test, we have rapid alternating movement. Remember, this is checking your cerebellum, which is that portion in the back of your brain. Rapid alternating movement, that is on your head to toe assessment. You want to have the patient pat their knees with their hands and then pat their knees with the dorsum of their hand. And they want to do that as fast as possible. You can do it relatively fast. You can try it on yourself. This is really assessing coordination. Some other things that will also test that function are finger to finger tests. So you have the patient look at you and reach out and touch your finger with their finger. They may touch their finger to their nose, or then they can run their heel up their shin. So that's a good test to test the cerebellar function. And I'll let you guys watch the video on your own. Okay, so the next cerebellar function test are balance tests. So we can observe gait, but we can also observe the Romberg test. So the Romberg, you're going to have the person stand up with their feet together and arms to the side. Once in a stable position, ask him or her to close their eyes and hold the position. Wait about 20 seconds. Normally, a person can maintain posture and balance even with the visual orienting information blocked, although slight side swaying may occur. So abnormals would be sways, falls, widens the base of feet to avoid falling. Positive Romberg sign is a loss of balance that occurs when closing the eyes. You eliminate the advantage of orientation with the eyes, which had compensated for sensory loss. A positive Romberg sign can occur with cerebellar ataxia. So you actually have that with alcohol intoxication, which is why patients, so you can try it on anybody you know who's drunk, which would be very unsafe, so don't do that. But if you did try a Romberg sign on them, they would fall over because of the issue with the cerebellum, and we can see that with multiple sclerosis as well. So for gait, you just want to observe the person walking 10 to 20 feet, and then you can ask them to do tandem walking in a straight line heel to toe. So next is assessing the sensory information. So we've got two features, we've got sensory, which is bringing information in, and motor, which is taking information out. So with sensory, we can detect pain. So it would be normal that somebody could detect pain. So you can break a popsicle stick, or I guess tongue depressor is what it's called, in half and kind of touch them with the sharp edge and feel that sensation. Light touch, you can have them close their eyes and apply a wisp of cotton to the skin, and they can tell you where it is. Vibration, you can get a tuning fork and then have, touch the area of their body with that tuning fork. Just strike it on the heel of your hand and hold the base on the bony surface, let's say finger or great toe, and then ask them, when the vibration starts and stops. You're obviously feeling it, so you can feel that as well. So if they're unable to feel vibration, they may have peripheral neuropathy. We talked about peripheral neuropathy with diabetes, right? That really chronically elevated glucose can cause damage to the nerves. Patients may also have peripheral neuropathy with alcoholism. So the loss of vibrational sense with those disorders are the first to occur. So they may feel touch and things like that, but may be unable to feel vibration. So the neuropathy is often going to be worse in the feet. So that would be worth doing that test. So position or kinesthesia is to detect where their body is in space. So you may move their big toe up or down and ask them the way you're moving it. Same with fingers. Stereognosis, it's a new term, so it's important to know. You're going to put a familiar object in the patient's hand and ask them to identify it. So maybe like a key or a coin. Astereognosis, which if you think A is without, so without stereognosis, is the inability to identify object correctly. So we would think of maybe there was damage to the sensory cortex, like somebody had a stroke. Graphesthesia is the ability for somebody to know what number or letter you write in their hand. So let's say you traced A on my hand, I should be able to tell you that it's A. So if somebody is unable to do that, it's very similar to the stereognosis where it would be damaged within the sensory cortex. So 2-point discrimination is on here on the slide. That's to test the ability to distinguish separation of two simultaneous pinpoints on the skin. All right, so next is about your deep tendon reflexes. There's a rating scale here. So your reflexes, these you don't have to think about, they're automatic responses. You need the person to have a very relaxed limb. So the muscle should be slightly stretched. So I think the most common one we see is the patellar reflex. So your provider may have done that. You sit on the exam table and they tap your knee with that reflex hammer and your knee should, go out. So that tendon or that muscle is kind of stretched, right? And you're supporting your leg on the exam table. So this requires some skill to be able to do. So you want to strike a very brief, specific blow that bounces promptly on the tendon. You don't want to let the hammer rest on the tendon. You want to strike and then remove. So it's the swing of the hammer, not the strength of the strike, that gets the best results. You want to use the pointed end of the reflex hammer when aiming it at smaller targets, such as your thumb on the tendon site, or the flat end when you're doing like the knee. That'll help reduce some of the pain. So just use enough force to get a response. So this is how we rate the reflexes, similar rating scale to pulses. So 4+ would be hyperactive with clonus. Clonus just means that that reflex just keeps occurring. 3+ is brisker than average, but may indicate disease, may not. 2+ is average. 1+ is diminished, occurs only with reinforcement, and then 0 is no reflexes at all. So this is a subjective scale. So you need to kind of get used to kind of like listening to vowel sounds. You start to know after you examine so many patients what normal is. So healthy people may have diminished reflexes or they may have brisk ones. You just want to interpret it within the context of the rest of the neurologic exam. So if nothing is abnormal and they just have these very brisk reflexes, my reflexes are just very strong and very fast. I don't know why that is. The rest of my neuro exam is probably normal. So you want to interpret that. So if you just have this, brisk and nothing else is going on, but let's say somebody's got something else going on and you notice that, that would be a finding to know. So some areas where we have reflexes. So we have the bicep reflex. So the biceps reflex test cervical nerve 5 to 6. So this is, I showed you those dermatomes, very similar. It's looking at those actual spinal nerves. So for the biceps reflex, you're going to support the person's forearm on yours. This position relaxes and partially flexes the person's arm. You want to place your thumb on the bicep tendon and strike a blow onto your thumb. Kind of how we did CVA tenderness. You know, you had your body part and then you struck your body part. So you can feel as well as see the normal response, which is contraction of the bicep muscle and flexion of the forearm. So you can see down at the bottom of 649, you're going to put your thumb over that tendon. And if you move your arm back and forth, you can feel kind of that hard part. That's your tendon. And then you're going to strike your thumb. You should feel that bicep flex and the forearm flex as well. All right. So the triceps reflex is on page 650. That's checking spinal nerves C7 to C8. You can tell the person, just let your arm go dead. Sometimes easier said than done, but you're going to hold on the biceps. So you're going to hold on the arm and you are going to strike the tricep tendon just above the elbow. Normally they would extend the forearm. So the forearm would go out to be straight. The next is a brachioradialis. So this is on your wrist. So you want to hold the person's thumb to suspend the forearm in relaxation, strike the forearm directly about 2 to 3 centimeters above the radial styloid process. So that area that sticks out. Normally they would flex and supinate the forearm. Quadriceps reflex, which is not shown here. This is the knee jerk. So that is the patellar reflex. They just have a different name for it. So this is L2 to L4. You want to let the lower legs dangle freely to flex the knee and stretch the tendon. Strike the tendon directly below the patella. So you can see here, extension of the lower leg is an expected response. You will also palpate contraction of the quadriceps. There's a picture here on 651 about what to do if somebody is in a supine position. So that's helpful. And then there's the Achilles reflex, which is the ankle jerk. So this is L5 to S2. So you want to position the person with the knee flexed and the hip externally rotated. Hold the foot in dorsiflexion. So you can see on 651, she's holding the foot and she's striking the Achilles tendon. So that's that rigid structure on the back of your leg. So feel the normal response as the foot plantar flexes against your hand, which remember plantar flexion is going down. So your book talks a little bit about clonus. Clonus is just a repeated reflex muscular movement. It occurs with some upper motor neuron diseases. So let's talk a little bit about the neurologic. So your book talks about it being the neurologic recheck. So I think it's just the neurologic. It's a very basic neurologic assessment, if you will. So let's talk about the Glasgow Coma Scale really quick here. So the Glasgow Coma Scale is one that we use a lot in kind of trauma settings. And let's end this video here and we'll start it.